Hello again and welcome back to our discussion on sleep. And with me in studio is Dr. Walter Lemon, a neurologist at Barnes-Jewish Hospital. Dr. Joseph Ogile is founder and CEO of the Clayton Sleep Institute. And joining us by phone from Chicago, Dr. Stephen Sheldon, who is director of the Sleep Medicine Center at Children's Memorial Hospital in Chicago. A couple of very quick questions here. Can we catch up on sleep that we've lost?
It depends on the amount of sleep that's been lost, and it depends on the amount of time. Recovery sleep is definitely possible if you have an acute sleep loss, acute sleep deprivation. There can be recovery sleep. But if it is lost over a long period of time, it is really unknown whether that can be made up.
Anything to add to that, gentlemen?
We call it sleep debt, and we tell patients that just like a home mortgage, most of it has to be paid back. Maybe unlike some home mortgages, but most of the time you've got to pay it back.
Let's talk about some of the health problems that are most familiar to most people. I think insomnia has been mentioned being one of the big ones. 10 or 11%, Dr. Ogile, I think you said, suffer from that. Do we know what causes it? Do we know how to specifically deal with it?
Insomnia is quite varied. The most standard definition would be the inability to get to sleep or stay asleep with a daytime consequence. So it alludes back to your earlier question. That's a very generic explanation. We see people come in with varied presentations of this all day long. Some of them related to other illnesses. So as Dr. Sheldon was talking about, the key is a visit with your physician to make an accurate diagnosis. The insomnia frequently is the sleep and the insomnia are victims of something else that's going on, is how we explain it. To give you a clinical example, frequently people come in, the most common cause of disrupted insomnia type sleep is stress and anxiety. Sometimes folks come in, they're having a very serious episode in their life or a chronic episode. It affects their sleep, but the best therapy is a comprehensive approach to what's happening to them on a daily basis. And we need to be open to addressing those issues in a complete and holistic way with the patient.
Well, let's define it to be sure that we know, that everyone knows what we're talking about. Some people might think they have insomnia when they don't. They wake up at night and then they go back to sleep. What exactly is insomnia defined?
So defined, it's inability to get to sleep, stay asleep, or have restorative sleep with a daytime consequence. To give you a very quick example, Don, I had two patients. They very conveniently put themselves in rooms next to each other in my office. The first patient, when you walked in, he looked exhausted. He was having trouble getting to sleep every night. He was miserable. He clearly had the diagnosis of insomnia. The other gentleman was crisply dressed, talking on his cell phone, walking around, energetic. I said, why are you here? He said, because I think I have insomnia. And I said, he said, my coworkers made me come in. He only needed to sleep 6.5 hours per night, had absolutely no daytime consequences. He did not have insomnia.
Getting to the issue of causes, once the diagnosis is recognized and made, I think it's important to recognize that true psychiatric disease, mood disturbance, bipolar affective disorder or manic depressive disease, and unipolar depression both have consequences on sleep. Physical discomfort can lead to a restless night, so chronic things like arthritis that make people uncomfortable. And I think Joe can speak to this, or Steve can, the issue of leg movement abnormalities can keep people up and can keep bed partners up as well.
I think that those are very important issues. One thing that one must consider is the chicken or the egg. Which comes first? Is the sleep problem causing the daytime symptoms, or is there an underlying problem that causes both daytime symptoms and nighttime symptoms? The other issue is that insomnia in adults is exquisitely different than insomnia in children. Pediatric insomnia have many different and varied causes, from behavioral issues to biological issues, and it often comes to the attention of the pediatrician only because the parents have insomnia, which is an environmental insomnia because the children wake them up in the middle of the night, and the parents bring the children to the healthcare practitioner because the parent is sleepless, because the child is sleepless. Children are supposed to be sleepless. They're developing sleep as a neurologic function, just like every other biological function that is developed in childhood, like walking and talking. So a child cannot sleep like an adult. An adult can sleep like a child by napping and sleeping when the child sleeps, but demanding that a sleepless child sleep like the parent is inappropriate and difficult to do, if not impossible.
While we're on the subject of parents and children, and I want to touch upon this, we have so many callers, I want to get to them and other things, but Dr. Sheldon, you're the guy to talk to with regard to co-sleeping. We had a tragedy a couple of weeks ago here in our area here, in which a child suffocated and died sleeping with his father. His father rolled over on him, apparently, and the child died. This is one area that you're obviously concerned about.
Yes, co-sleeping is an issue if the co-sleeping environment is not safe for the child. And a soft bed, co-sleeping in a bed with a parent who may have had a glass of wine before dinner, or who may have taken a sleeping pill to fall asleep, can be exquisitely dangerous for the child. Many cultures, though, throughout the world do co-sleep when it is culturally and socially acceptable, and the family bed is acceptable in many places throughout the world. The difference is that in those societies that do co-sleep, the sleeping environment is quite safe because most of them are sleeping on the floor. Not in soft beds with pillows and covers and blankets. Most of them are sleeping on hard surfaces that's safe for the child. Therefore, co-sleeping is really dependent upon who chooses to co-sleep, and often parents in industrialized societies will choose to co-sleep with the child because it's easier than having the child sleep alone. There are many interventions for that and many ways to approach that, but co-sleeping in an unsafe environment can be hazardous. Co-sleeping in an environment that's safe is done throughout the world.
Is there some very quick advice you could give to parents with regard to that choice? I mean, most of the time it's going to be on a sofa or in the parent's bed.
It really depends on who is making the choice to co-sleep. If it is the parent's culture and it is their desire to co-sleep, and the environment, the sleeping environment is safe for the child, then it is the parent's decision to co-sleep. If the environment is not safe for the child, then it should not be done. If it is the child's choice because they have nighttime fears or they have sleep onset association problems, which we can discuss later, and the child has frequent curtain calls and keeps on coming out of the bedroom, the only way the parent can get the child into to sleep is to sleep with them in the parent's bed. Then it's likely inappropriate. Sleep onset association, because the parents then have become the child's pillow. So the breaking that cycle, breaking that conditioning, and getting the child to sleep in their own bed is a process.
I love the term curtain calls with regard to the children waking up. Two other things I want to touch upon quickly, and then I must get to the phones. Dr. Lemon, you indicated during one of the breaks that one of the things we ought to be concerned about are AFib, atrial fibrillation, strokes, that sleep can have an impact on some of these potentially very dangerous things.
Well, that's right. The atrial fibrillation, of course, is a condition where the upper chambers of the heart are not beating in a synchronized fashion. Blood sits there in a stagnant pool, and that stagnant blood can clot. That clot can move down into the lower chamber and out to the body, and if you know or don't know, 20% of the cardiac output goes to the head, to the brain. And so stroke is a concern.
But what's the role of sleep here?
The role is through sleep apnea. Untreated sleep apnea can cause atrial fibrillation, and atrial fibrillation, if it's not dealt with preventatively, can lead to stroke. Now, admittedly, a neurologist sees the funnel effect of the patients who unfortunately have a stroke, but as I tell patients, a stroke is a no-take-back move, like in checkers, and you take your hand off the piece and that's it. So I'm an activist in preventing clotting subject to atrial fibrillation.
I understand, and I'll ask Dr. Ojal very quickly to tell us what sleep apnea actually is. We hear the term but may not know what it is.
So sleep apnea is a generic term. Apnea means lack of breath in Greek, so it's a lack of breath when you sleep. The most common form of this by far is what's called obstructive sleep apnea, where you have extra tissue in the back of your throat. When you go to sleep, that tissue collapses as you sleep and obstructs the breathing pipe, causing the lack of breath. So the person's trying to breathe, but they can't get the air past the obstruction easily. There's another form called central sleep apnea, where your brain just doesn't tell your body to breathe correctly. That's less common. We see that occasionally at altitude with heart failure.
If you're having these symptoms, do you know it, or because you're asleep, you don't know it?
The quick answer is most people in reality do know it. There are some who want to deny it, but certainly the spouse or bed partner know it usually clearly. The observation by a person that's watching someone sleep is 90% accurate, but most patients know it because they're having symptoms or sequelae from it. They wake up choking, gasping, they're tired, they go on trips and nobody wants to sleep in their tent or bedroom and whatnot. So
right. Get it taken care of as soon as you feel that that's what your problem is. Let's go to the phones again.
Can I just make one comment?
Of course.
Before, I think it's important to understand that obstructive sleep apnea and sleep apnea also occurs in children, likely at the same frequency as it does in adults, and so children do have sleep apnea as well, and this needs to be addressed.
We have an email here from Terry who says, do all people who snore have sleep apnea?
the answer is no. Snoring may occur without sleep apnea. It is commonly associated with obstructive sleep apnea. So snoring in anybody who has underlying symptoms of being fatigued, witnessed events, any cardiac issue, they should be evaluated. But snoring itself can occur without other sequelae.
There are some data, though, in children that snoring may be part of a continuum of symptoms of obstructive sleep disordered breathing, and some children that only snore can end up with neurocognitive deficits. So they don't do as well in school, and once the cause for the snoring is identified and it is treated, they actually do better.
I would agree with that, and all the other. I would thank Stephen for throwing that in, as well as the issue with pregnancy and snoring. There's data that in pregnancy, snoring is associated with increased complications and less successful children.
This sleep is a dangerous thing.
Well, I have to emphasize. I do have to emphasize that habitual loud snoring in a child is not normal.
Mm-hmm.
And it should be pursued.
All right, preferably before that first curtain call, right?
That's correct.
Let's take some calls here. A lot of folks want to chat.